Hello, this is Symptoms in Pediatrics, presented by the SchrDbb, with reference a practical guide to issue taking and clinical examination by Anwar Qais Saadoon. Hello, so today we are going to start with all the symptoms in pediatrics, and we are going to start with dyspnea. So what's the definition of dyspnea? Dyspnea is just defined as shortness of breath. It can be defined as a subjective uncomfortable feeling of having difficult or labored respiration. That's dyspnea. So if you have a patient that has difficulty in breathing, that is just dyspnea. Now, dyspnea can have very varied causes. It can be 1 pulmonary, it can be 2 cardiac, and 3 systemic. Systemic in cases where you have blood loss. If you have blood loss, you can have dyspnea because the body wants to compensate with the blood loss by breathing more, such that oxygen can be perfused more since the red blood cells have decreased. Or you can have a systemic condition where you have acidosis, and acidosis is going to result in dyspnea, such that the carbon dioxide can be released, and that according to Le Chatelier's principle, there is a shift of hydrogen carbonate to carbon dioxide, so that hydrogen should be reduced inside the blood. So those are the 3 main causes of dyspnea: pulmonary, cardiac, and systemic causes. Now the next one that we're going to visualize is the general issue taking in dyspnea. So you have to first have the identity of the patient. The identity, the age is important. You have the chief complaint is dyspnea. Now, how do you take the history of a patient with dyspnea? So if you have a patient with dyspnea, you should take the history as such. 1, there must be an onset. If the onset is sudden, it means that it can be an inhaled body or it's a lung collapse. If the onset is gradual, then you can think of asthma or diabetic ketoacidosis. You have the duration. Duration is acute or chronic. Acute is less than 2 weeks. Chronic is more than 2 weeks. Timing of the dyspnea. The timing of the dyspnea is just meaning if it is intermittent or if it is constant. So that's it. Does it ever awake? The timing of the dyspnea is if it's in the morning, if it's in the night, if it's in the daytime, and all that. So that's the timing of dyspnea. What was the child doing before he has the onset of dyspnea? You can have certain precipitating factors of the dyspnea. We have the frequency of the attack. Frequency is intermittent or constant. If it is intermittent, how many times of episode of dyspnea you can have in one day. The next thing is the severity of the dyspnea. The severity, does the shortness of breath restrict the child from daily activity? You need to know that what in severity there are 2 main scales which are used to describe the severity of dyspnea. We have the MRC scale and we have the New York Heart Association scales. The New York Heart Association is mostly used for cardiac diseases, where we have dyspnea grade 1. Dyspnea grade 1 is going to be characterized as being upon strenuous exercises. When you have dyspnea with strenuous exercises. Dyspnea grade 2 is when you have with moderate exercises. Dyspnea grade 3 is when you have mild exercises, and dyspnea grade 4 is when you have dyspnea at rest. While in case of the MRC scale, the MRC scale is mostly used when you have a dyspnea with, as a result of respiratory diseases. Now, when you have dyspnea as a result of respiratory disease, you use the MRC grade classification. So it's classified from 1 to 5. So dyspnea MRC class 1 is going to be when you have dyspnea upon strenuous exercises. Now, MRC class 2 is when you have dyspnea upon climbing stairs. MRC grade 3 is when you have dyspnea when you are moving at a distance of when you have dyspnea when you are moving every distance of 100 meters. MRC stage 4 is when you have dyspnea, you are not capable of maintaining the same pace with the other people. And then MRC grade 5 is when you have dyspnea at rest. So that's it. So now the next one now is dyspnea. We have aggravating factors or relieving factors of dyspnea. Is it upon exercise? Is it with a certain perfume? Is it with dust? Is it with, so we can think of or relieving factors with bronchodilators and other. Now, the next one now is associated symptoms. Is it associated with cough during what's the duration in the day? Is it associated with sputum? Is there hemoptysis? Is there fever? Is there chest pain? So as from this chest pain, sore throat, running nose, you can think of other it can make you go to a particular disease more than the other. So now the other one now in pediatrics that you have to know is the birth history. So birth history, we have dyspnea in a patient with in a neonate. You have to know about the birth history, the maternal age. If the child had gestational diabetes, he can have dyspnea. Why? Because gestational diabetes is going to prone the reduction in corticoids. So we have reduction in corticosteroids. So the maturation, long maturation in children for mother with gestational diabetes are prone to have acute respiratory distress syndrome. Why? Because in these children who have in the mother who have diabetes, there is the maturation of the lung, the period of maturation of the lung is reduced compared to children where the maturation is normal. Example, normally the full maturation in a normal child, child should be at 34 weeks of gestation, but from a child with a mother having gestational diabetes is going to be at 36 weeks of gestation. That's different. Now, you have maternal chorioamnionitis. If the mother had chorioamnionitis, can have dyspnea from neonatal sepsis because the child has that. You have mode of delivery. You have to think of mode of delivery. You need to know that what the child may have dyspnea in case of with cesarean section. Cesarean section. Why? Because cesarean section is going to result to a transient tachypnea of the newborn. That's what causes the dyspnea there. Why? Because you need to know that what when you give birth to a child through the normal birth canal, the child passes through a period of stress, and then there is compression of the chest wall such that all the amniotic fluid that was inside the lungs is going to be released through the mouth. Are you getting? But now, if a child is just born by cesarean section, it's not going to pass through the other stress, and there is not going to be compression of the lungs. So it means that what the amniotic fluids are going to stay and accumulate inside the lungs. So that's why the child who is born from cesarean section has a transient tachypnea of the newborn. So ask whether it was an elective or emergency surgery. So if it's an emergency cesarean section, you can think of an acute fetal distress which continues with the neonatal asphyxia in the child. So you have any intervention needed during labor? Was there prolonged labor? Was there meconium? So all that is only prone to acute fetal distress. Was there meconium stained amniotic fluid? If there is meconium stained amniotic fluid, it may not be acute fetal distress, but instead a meconium aspiration. So was there meconium stained amniotic fluid? Was there a history of birth asphyxia? Was there gestational what was the gestational age of birth? So all these are very important when you have to take the past history of the child. The other passage is the medical and the surgical issue. Does the child have asthma? Does the child have recurrent wheezes? Does the child has diabetes? Does the child has congenital heart disease, heart failure, cardiomyopathy? So all these are very important. Then the next one is medication issue of the child. Does the child take beta blockers? And you know that beta blockers are going to block the bronchodilation, so they cause bronchoconstriction. So does it response? Do they respond to bronchodilator, corticosteroids, and all that? Immunization issue. So if you have a child with dyspnea, you can think of an upper respiratory tract or a lower respiratory tract infection. An example of things that can cause lower respiratory tract infection, you have tuberculosis. So you have to know if the child has an immunization issue with Bacillus Guerin, that is BCG. You want to know if the child had the vaccination for DPT, that is diphtheria, pertussis, tetanus, because all that diphtheria and pertussis can cause upper respiratory tract infection. You want to know if the child had been immunized for measles, mumps, and rubella, MMR. So because this can cause also respiratory tract infection. You want to know if he has received oral polio, but oral polio respiratory tract infection is less likely. It is much more going to cause a neuropathy, polio virus. So we want to know if the child has received hepatitis B and A, though they are less likely to cause this. The next one which can cause also dyspnea is pneumococcal bacteria. So pneumococcal vaccine is going to be very important to prevent the respiratory tract infection. The next thing is the feeding and the dietary history. The feeding and the dietary history. So feeding difficulty, if the child has feeding difficulty, if fast breathing, if diaphoresis when feeding. So you have some children that neonate that when they feed, that's the time that they have respiratory difficulty. So if you have a dyspnea which is associated with feeding in a neonate, you have to think of a tracheoesophageal fistula. So that's what you have to think. You have prolonged feeding time, you have reduced volume of feeding. You can think of tracheoesophageal fistula, that's a congenital abnormality. You have family history of asthma. If there's family history of asthma, you can think of asthma. If there's family history of allergies such as atopic dermatitis, or you have allergic rhinitis, you can think still of asthma, because a triad of allergic dermatitis plus allergic rhinitis plus asthma is a triad called atopy, which is involved in allergy. So if you have all that in the family, you can think already of asthma as being the cause of this. So we have congenital heart disease. Social issue. For the social issue, you have, has the child traveled and gone toward an overcrowded house? Was there anyone in the home who had respiratory symptoms? Because it can be an infectious origin. Or is there pollution with the use of wood, the coal, which can cause allergies? Is there smoking in the house? Are they smoking, active or passive smoking? Are they doing drug addiction and all that? Then we have to know now a review of systems. So itching and rashes is for allergies. So if you don't have this itching and rashes, is go for an allergic dermatitis or an urticaria. So you have pallor, you have night sweating. If you have night sweating, you can think of tuberculosis. If you have pallor, you can think of a systemic condition such as anemia, that is also the dyspnea. If you have poor weight gain, you can think of a congenital abnormality such as tracheoesophageal fistula. If you have diarrhea, vomiting, seizures, you can think of a severe, in case of vomiting, you can think of a severe upper respiratory tract infection like in Bordetella pertussis, where the child can vomit. If you have seizures, if you have limb weakness and headache, you can think of other things resulting to that. Seizures, limb weakness and headache mostly have it to deal with a dyspnea which comes from the central nervous system. The next thing is knowing the child age is important because the causes of dyspnea may vary with age. Dyspnea with chest pain may suggest, if you have dyspnea with chest pain, may suggest pneumothorax, may suggest a rib fracture from trauma or pleurisy. So if you have a dyspnea, I have difficulty in breathing, and then I have chest pain, I think of pneumothorax, I think of rib fracture if there is trauma, and then I think of pleurisy. If there is fever with dyspnea, I should think of an infectious origin like pneumonia, a pleural effusion resulting to a pleural effusion, or I think of a bronchitis, respiratory bronchitis. Now the next one is sudden onset of dyspnea may suggest an inhaled fall. If you have a sudden onset of dyspnea, you think of an inhaled foreign body or lung collapse. Dyspnea of asthma and diabetic ketoacidosis are usually developed after several hours or gradual onset. You have orthopnea. If you have orthopnea, is dyspnea that worsens when lying down, and you think of a left ventricular failure when you have that, or you think of an obstructive airway disease. So orthopnea is not only peculiar for left ventricular failure. Are you getting? Orthopnea is also as a result of an obstructive airway disease, like in the case of an asthma. Asthma is an obstructive airway disease. Emphysema is an obstructive airway disease. Chronic bronchitis is an obstructive airway disease. It's not only peculiar for left ventricular failure. Are you getting? So if you have a patient that has orthopnea, you can think also of obstructive airway disease as well as left ventricular failure. The next one you have, or do you think of, is muscle weakness. Then you have platypnea. Platypnea is shortness of breath that occur in upright position. Platypnea. shortness of breath that occur in upright position and is alleviated when you are going supine. So in general, the causes of platypnea is going to be intracardiac, when you have an intracardiac abnormality, when you have a vascular abnormality, and when you have a parenchymal lung shunt. So all this platypnea is mostly when there is a shunt. When you are standing up, you see that most of your blood is going to pull down to the lower limbs. So when you lie down, when you stand up, most of the blood pull down to the lower limbs, and when you lie down, the blood come back to the central part of the body. So if you have things like shunt which reduces the blood flow to the lungs, and you pull down all your blood to the lower level when standing, you realize that you're going to have platypnea. If you have an intracardiac or vascular abnormality that bypasses the heart or bypasses the lung, you see that you have, it's better for you to lie down in order for you to have more breathing. Are you getting? So example of things where you have vascular abnormality with a shunt can also be in the case of a patent ductus arteriosus. The next one now, we also have a bradypnea. We also have a bendopnea. Bendopnea is dyspnea when you are bending forward and it is relieving when you stop bending. That's bendopnea. The next one, you have heroin. So heroin can cause bronchospasm and can be relieved by bronchodilators. Furthermore, it is infrequently precipitate non-cardiogenic pulmonary edema. So that's it. So the handout was on dyspnea. Thank you very much for your attention.